just now. However, good evening to everyone that's managed to join successfully. I'm James Ritchie. I'd like to welcome you all on behalf of the Scientific and Education Committees of BOFAS to this evening's Virtual Journal Club. This is the fifth journal club in a series of 6, which has been very kindly sponsored by DJO. And as always, I'd like to thank them for their continued support, without which these undertakings could not have taken place. And indeed, we'd have struggled very much for educational material and opportunities during the recent confusion. This evening's meeting will follow format as previously. There are 2 papers for discussion, both relating to the topic of end-stage hindfoot arthritis. The first paper for discussion is the paper by Ian Winson et al. On arthroscopic ankle arthrodesis. That will be presented by Ms. Shipa Jha, and then Ian will reflect on the paper, and we'll have questions as moderated by my esteemed colleague, Mr. Callum Clarke. Thereafter, the second paper is a comparative series on total ankle replacement published by Sunil Dhar and his group, which will be presented by Mr. Blair Tweedie, and then reflected on by Sunil, and questions will follow, chaired by my other highly esteemed colleague, Mr. Dave Townshend. So first paper, arthroscopic ankle arthrodesis, and I'll hand over now to Ms. Shipa Jha to review that paper.
But there was limited information on functional outcomes. So the aims of the Bristol the Windsor Foot and Ankle Fellow, and thank you for this opportunity to present at the BOFAS Journal Club. I'll be talking about the arthroscopic ankle arthrodesis paper published by the Bristol Group in JBJS 2005. So back in 2005, where were we? Well, those were the days when George W. Bush seemed like the worst possible US president, and the closest thing we had to a horrendous viral pandemic was a Crazy Frog song. But more importantly, what were we up to in terms of ankle arthritis back then? Well, arthroscopic arthrodesis was first described in 1983, and as you can see from this table, there were a number of studies published prior to 2005, but they were all very small, and they were generally American. They did demonstrate good union rates, but there was limited information on functional outcomes. So the aims of the Bristol Group were to look at the mid to long-term results of arthroscopic ankle fusion, look at the operative indications, look at the optimal post-operative management, and the reasons for dissatisfaction. This was a retrospective single-surgeon case series. There were 118 ankle fusions in 116 patients between 1991 and 2002. They had a very good follow-up rate, with only 3 patients lost to follow-up and 9 patients dying before final review. The mean follow-up time was 65 months, and these patients were followed up by clinical telephone call. In terms of baseline data and demographics, this was collected on gender, size, age of operation and BMI, as well as smoking status, with the majority of patients being non-smokers. The underlying preoperative diagnosis was post-traumatic arthritis in the majority of patients, followed by primary OA, inflammatory arthropathy and AVN. Weight-bearing AP and lateral X-rays were taken preoperatively, and the coronal level of coronal deformity was measured, as well as concomitant osteoarthritis in the adjacent joints documented via Kellgren and Lawrence grading. As you can see from this table, there was a wide range of preoperative deformity in these patients, with the majority of them having a fairly neutral alignment. Post-operative AP and lateral X-rays were also taken, and the plantar dorsiflexion fusion position was documented. Union was defined as bridging trabeculae with a clinically stable ankle that was painless on manipulation and weight bearing, with no failure of fixation or change in position. In terms of operative technique, the indication for arthroscopic versus open surgery was if the foot could be fixed pronation or supination. The general operative technique is very recognisable, with the patient supine, standard anteromedial and anterior to healthy cancellous bone. In this paper, interestingly, the lateral from the medial side parallel on the AP and lateral views. The option of oscalcis osteotomy was taken where there was varus or valgus deformity following the ankle fusion. The patients were initially managed in a back slab, then a cast. They were non-weight bearing for 2 weeks, with a further 6 weeks partial weight bearing, and in weeks 6 to 12 they were allowed to be full weight bearing in a walking boot or until clinical radiography. The clinical outcomes in this paper were measured in 2 ways. Firstly, subjective outcomes were graded into 4 groups: excellent, which was a painless ankle with no limb or occupational restriction fusion, ranging from poor, which was a non-union or severe pain. Patient satisfaction was also recorded and divided into 3 groups: satisfied without reservation, satisfied with reservation, and dissatisfied. In terms of results, the mean length of stay in this cohort was 4 days, ranging from 1 to 21. The authors noted that this was perhaps a longer length of stay than that described in other papers, but they noted the extended length of stay patients tended to be those with polyarthropathy who had difficulty adjusting to the non-weight bearing status. The mean time of union was 12 weeks in this study. However, this is confounded somewhat by the fact that in the latter part of the series, the first set of radiographs was only taken at 12 weeks, so there is every possibility that they could have united prior to that. In terms of non-union, they had a very low non-union rate with 9 patients. Of these, 7 out of 9 were successfully fused later on with an open technique, 1 awaited fusion and 1 chose non-operative treatment. The authors made a note of the fact that of these non-unions, 4 out of 9 of them occurred within the first 8 operations. operations performed. They noted that these early cases had been immobilised for a shorter period of 7 to 11 weeks, and this policy was later changed to 12 weeks. Following this change in policy, they noted the non-union rate dropped to 4.7%. In terms of risk factors for non-union, they noted that 33% of patients who did not unite smoked perioperatively, which is double the rate in successful unions. One non-union was due to deep infection, and BMI and age did not appear to be associated. In terms of other complications, the most frequent complication was patients requiring removal of prominent screws, which occurred in 22 patients. There were 3 superficial infections, 2 DVTs, 1 revision due to equinus, and 1 stress fracture at the level of the proximal screw head, which was successfully treated in calf. In terms of adjacent joint fusions, 6 out of 116 patients required a subsequent subtalar fusion, and 4 out of 6 of these patients had a preoperative diagnosis of post-traumatic arthritis. The mean time between ankle and subtalar fusions was around 48 months. Interestingly, although the mean pre-op Kellgren and Lawrence subtalar joint score was 2.35, in terms of patients who had a high Kellgren and Lawrence score of the subtalar joint preoperatively, the rates of requiring a subsequent subtalar fusion were very low. So of the 6 patients who were grade 4 preoperatively, only 1 went on to have a subtalar fusion, and of the 28 that were grade 3 preoperatively, only 2 went on to have a subtalar fusion. The mean subtalar Kellgren and Lawrence score preoperatively was 2.8 in those who subsequently required fusion. 1 rheumatoid patient underwent a triple fusion, and there was 1 patient who had a talonavicular fusion. Notably, all inflammatory arthropathy patients were united and satisfied without reservation, although other joints were involved often. Actually, only 1 patient went on to have a triple fusion. The results demonstrated a very satisfactory mean position of fusion in terms of the dorsiflexion position, and only 4 of the patients required an os-calcis osteotomy, with a further 2 requiring TA lengthening. The authors do also mention that during the study period, 10 primary open fusions were performed, which is actually only 8% of all ankle arthrodesis at this unit, and that was due to pre-op coronal deformity defined to be too much for an arthroscopic fusion. They've also found that significant coronal deformity at the ankle joint was often associated with subtalar pain and deformity, and these patients often required a hindfoot nail, and there were 60 of these performed during the study period. In terms of clinical outcomes, you can see that the majority of the patients had an excellent or good clinical outcome. Of the 11 patients that had a poor clinical outcome, 9 of these were non-unions, and 2 went on to have subsequent subtalar fusion, and in spite of this still had ongoing pain. In terms of patient satisfaction, the majority of patients were satisfied without reservation. Only 6 patients were dissatisfied, and again, a third of these had subsequent subtalar fusion, half of them had subtalar symptoms, and 1 went on to a talonavicular fusion. So, in terms of the discussion and conclusions of this paper, firstly, the authors commented on arthroscopic arthrodesis and deformity. They noted that their series included patients with deformities of 25 degrees and more, and previous studies had mainly demonstrated arthroscopic arthrodesis as an in situ type procedure. They therefore suggested that indications can be extended after experience is gained with minimally deformed ankles, and felt that more than 90% of ankle arthrodesis was amenable to arthroscopic preparation in this series. They also noted that there was no requirement to fuse the talofibular surface, and it was sufficient to clear the lateral gutter enough to allow tibio-talar opposition and achieve good results from doing this technique, and they had no post-operative symptoms ascribed to this method. In terms of union time, previous studies had already shown a decreased time to union with arthroscopic ankle fusion. With this study, given that the first x-rays were mainly taken after 12 weeks, it was difficult to comment on that. The authors did note a learning curve with this procedure, with 4 of the first 8 cases having a non-union, although this may also have been related to the shorter period of immobilisation in that group of patients. They noted that their length of stay was perhaps higher due to the rate of inflammatory arthropathy, making it more difficult for patients to non-weight bear safely. They also noted that there was a high rate of removal of screws. However, this was a simple day case procedure and there were no further complications. They suggested that all patients undergoing this procedure should be warned preoperatively about this as a frequent risk. In terms of adjacent OA, they noticed that although hindfoot arthritis is known to be common after fusion, their study by recording the preoperative Kellgren and Lawrence scores of adjacent joints demonstrated that it was common, in fact, prior to fusion. There were 45 grade 3 or 4 subtalar joints in this series, and actually only 3 of those required subtalar fusion. Having said that, the majority of dissatisfied patients did have ongoing hindfoot OA symptoms. They therefore concluded that it was difficult to decide who will develop worsening of their subtalar symptoms after ankle fusions, as X-rays do not seem to always correlate. They wondered if this certain cohort of patients would be better served with TAR or a combined subtalar-pantalar fusion. Although total ankle replacement results continue to improve, they felt at the time that arthrodesis performed arthroscopically remained the treatment of choice for many patients. In terms of critique of the paper, well, firstly, it is a retrospective case series rather than a prospective randomised controlled trial, as it would be in the ideal world. However, pragmatically speaking, this was a single surgeon consecutive case series with a low LTF rate and a good medium-term follow-up. So as consecutive case series go, it was a good quality paper. It perhaps would have been useful to have data on deformity in those treated with open surgery, as well as their clinical outcomes to help determine how much deformity is feasible to correct. The outcome measures in terms of function were not a formal validated outcome measure, and it was difficult to perform statistical analysis with small numbers in subgroups such as non-union. There is, however, excellent external validity with this being an NHS population, and the demographic data and the preoperative indications demonstrate that this patient cohort mirrors what we often see in our clinical practice in most units in the UK. This paper also does raise 2 important questions. Firstly, how much deformity can be treated with arthroscopic arthrodesis, and secondly, which patients are at a risk of subsequent subtalar fusion. This study suggests that preoperative subtalar OA is not a good protector. But the question we should ask ourselves is, 16 years later, have we done any better? The first table shows subsequent studies that have been done looking at arthroscopic ankle fusions, and as you can see, the Bristol series is still by far the largest consecutive series to date. There have been further studies which have been comparative, looking at arthroscopic versus open procedures, and these have demonstrated a better improvement in functional outcome scores, as well as shorter length of stays in the arthroscopic group. And all of these studies have demonstrated good union rates in arthroscopic ankle fusion. So this ongoing work has continued to establish arthroscopic arthrodesis as the gold standard. What about deformity? There's a recent study published by the Leicester Group comparing open versus arthroscopic fusion in deformity less than 15 degrees or more than 15 degrees, and they have actually found that arthroscopic ankle fusion has a favourable functional outcome and union rates in cases of deformity more than 15 degrees. In terms of subtalar progression, a study compared subsequent subtalar fusion following open versus arthroscopic fusion. They found that patients who underwent an open ankle fusion had a significantly more frequent rate of consequent subtalar arthrodesis than those undergoing arthroscopic arthrodesis. However, it's important to consider that this could be related to the underlying deformity in the hindfoot, which may well have led to bias. So in conclusion, this was a landmark paper establishing arthroscopic ankle arthrodesis as a widely adopted technique, and it remains the largest consecutive case series in the literature. Further studies and systematic reviews have reproduced the results of good clinical outcomes, union rates, and the success of the technique in coronal plane deformity. It does raise important questions about prediction of subtalar OA, which are yet to be fully answered. Thank you very much.
So good evening, everyone. Thanks for that, Shilpa. Before I go on and moderate this session, can I just remind people that you can submit questions via Q&A. So please go ahead and do that, because we can see those and we can field them and to the authors. So we're lucky to have Ian Winson, who's a very eminent figure in foot and ankle surgery in Europe, and a very eminent figure in orthopedics in Britain as well, and was obviously the senior author, and I think was almost single-handedly really popularized this technique, not just by this paper, Ian, but I think by visiting fellows and registrars and word of mouth and so on, you know, around that time through Britain. So can I just ask you, Ian, I've got some questions lined up, but can you just give us your sort of reflections on that paper, looking back at it now?
Yeah, I think the first thing to ask really is, what sort of paper is it?
Good evening.
Carry on.
Can people hear me all right? I do hope so.
I think so, Ian.
Yeah, okay. So what sort of paper is it? And really, in many ways, it now comes under a heading that we would recognise as, say, an equivalence or safety paper. In other words, you know, this was a relatively new technique. I actually picked it up when I was doing my fellowship work in Sweden, and a friend of mine, sadly now dead, Colin Dent, who was actually a hand surgeon, had done some cases in Cardiff, and his series probably wasn't overly optimistic, because Colin's relatively small series had a 50% what he called fibrous union. In other words, radiologically, they didn't look that great, but they seemed to solve the problem of pain. And really what we were trying to do was to establish the safety and efficacy of a technique. It also reflects my personal learning curve. And you know, happily being a bear of limited brain, my learning curve probably reflects all the mistakes anybody can ever make. So what did we really establish in terms of technique? We went through a process where, concealed within the paper, is a process of audit that went on after we'd done around about 25 cases. And that's when we discovered that we'd been lied to, i.e. everybody claiming that you could get more rapid union by doing it arthroscopically was in fact nonsense, really. We were getting a bit cavalier, getting people out of plaster early, getting them going, and then finding that they came back with pain and a non-union. And that reflects those early figures. And so after we'd done that roughly 20, 25 cases, we said, right, we really have to consolidate on a post-operative regime that is robust, reproducible, and produces good union rates. And what I would conclude from that is that the union rates we see at 12 weeks are, many people who do open arthrodesis will say, oh, my union is at 12 weeks. But actually, arthroscopic fusion is more consistent at 12 weeks. If you look at union rates in open fusion, then the mean union rate is more 16, 20 weeks. So we were getting greater consistency. It makes me smile, the one deep infection, which actually, if you look in the international published literature, it's mine. That is the one deep infection that is actually recorded in pretty much the whole of the literature. And though it's described in the paper as a non-union, the actual true story of that was that it was a guy who was very intuitively good as a patient and came back shortly after we sort of got him going after plaster, came off saying, I've got a problem. My ankle's become very sore, very inflamed. And essentially what he'd done is rub over his screws, which were a bit prominent, produced infection. They'd tracked down the cannulated screws. And ultimately he went on to union, because we took the screws out, debrided the screw holes, put him on antibiotics for about 3 months, put some more screws back on in later, and he actually did unite. So we were showing a very high level of safety. Now, when you actually look critically at this paper, what are the real weaknesses of it? And one is the fact that we largely scored them in truth by saying, do you like it or do you not like it? And why was that? Well, this is, of course, a historical thing, because in 2005, and in fact, of course, a lot of the data was collected prior to that, the BOFAS score was top of the league in terms of what scores people used, but is quite frankly a consistent bundle of nonsense. I could use a strong word. Why is that? Is because it combines inappropriate blocks of data. It combines data about pain with data about movement. And if you do that in a scoring system, then you find it very difficult to validate. And also you can't do it retrospectively. People do this, if you do it retrospectively, it's proven to be invalid. So the BOFAS score was not really an option. We knew that. We tested that ourselves and we said we shouldn't do that. We'd collected a lot of data using the SF12. And again, the problem with the SF12 is actually in foot and ankle cases, when you trace it through, it becomes invalid. And there's lots of reasons behind that. But so despite the fact that we thought it was a good idea, it was a simpler score than the SF12, across the whole of our orthopedic department, we've been collecting that data. We suddenly found that we had to junk it all for the foot and ankle stuff, because it clearly wasn't valid. And hence the reason why we went with the scoring systems we went. It was pre-MOXFQ, which we probably would have chosen to use now. In many ways, the issue of deformity makes me smile, because I almost forget that was commented on in this paper. And the better paper looking at deformity is almost certainly Steve Parsons' paper, which was published specifically to look at that and showed that the complication rates, the efficacy, and the scores were identical for people who had deformity more or less than 25 degrees. And his paper had pretty much matched groups for both. And of course, what that really says is that the deformity that's critical is not the deformity of the ankle. To technically correct an ankle deformity at the level of the ankle is easy arthroscopically. It's what is the rest of the foot doing underneath it, and what do you need to do to the rest of the foot? And in many ways, that's the same argument we would have with ankle replacements. So getting the ankle in the right position is technically quite easy. Getting the rest of the foot in position probably is what actually sorts out your maximum function, your maximum way that other joints will function. So it's very nice on a personal level to have the largest published series. At my stage of career, you can tick a certain box that says, "Ooh, I did that." But in truth, what it was about demonstrating a learning curve and showing that this was a safe, reproducible technique in a large number of patients. And just a final sort of comment is, at the moment, there's still this, to me, completely ridiculous ongoing debate about fusion versus ankle replacement. Why is it ridiculous? It's actually ridiculous because we're both groups of people, and I will do both, but both groups of people are feeding off one particular reality. The reality is 30 years ago, we had an absolute rubbish way of doing fusions and ankle replacements that would fall out if you put them in day one. Slightly overstating the case, but that's the truth. What we did know, and what several authors have shown, is that actually people with ankle arthritis really suffer. They suffer as badly as people with hip arthritis. They have the same quality of life as people who have congestive cardiac failure. And so when we get enthused about whatever we're using to treat their ankle arthritis, because we get so many patients coming back who are so grateful, we slightly forget the reason for that is we've treated them, and we've treated them well. And it doesn't actually tell us anything about the relative benefits of ankle fusion over ankle replacement or any silly debates like that. What we need to evolve long term is not an NGR-based, we're scoring ankle replacements. We need to gather much more data long term about the impact of ankle arthritis. And if you want, we want a very much more wide-ranging registry of ankle arthritis patients.
Yeah. Well, thanks for that, Ian. I think we're going to have to, we've got a number of questions, but because of the technical issues we had before, we're only going to have time for one quick one. So in 1 minute, I think one of the most interesting things about the paper was, one of the most interesting comments was about this issue of subtalar arthritis and how difficult it is to predict who does well and who does badly with an ankle fusion. Have you got any more idea about that in 15 years on?
The answer is no, not really. So we did a later paper, Barney Sheridan, when he was a senior trainee, looked at the comparison between a large group. It was, off the top of my head, I think it was somewhere between 60 and 70 of our group of arthroscopic ankle arthrodesis, and he did their pre-op scores very accurately and then looked at the correlation between their outcome in terms of outcome scores later and tried to see whether you could predict off those pre-op scores whether they were likely or not to need further surgery or to have ongoing symptoms. And he could find no correlation, despite the fact, again, I'm quoting it slightly off the top of my head, but it was over 80% of people had discernible arthritis somewhere in the rest of their hindfoot at the time they had an ankle fusion. So I think from that point of view, my conclusion is that one of the things that probably mitigates the presence of that arthritis is getting the alignment right. Yeah. And therefore you minimize the effect on other joints. And in one of the truisms of the comparator to open arthrodesis, when you look at open arthrodesis and their scoring processes, what it reflects is that you produce more effect with an open arthrodesis on the subtalar joint in the midfoot than you do with an arthroscopic ankle arthrodesis. Arthroscopic ankle arthrodesis really is a talocrural fusion. You occasionally have to add in the talofibular joint, but actually the vast majority of the time you don't. And so you're having a minimal effect on subtalar and midfoot. But it's still a big question. I think it's a big question about the whole of the evolution of how arthritis of the ankle has a knock-on effect on other joints. I think, yeah, we'll see what the ankle replacement statements are about this, but reality is that we really don't understand why some people become painful in other joints, either with fusion or replacement, and some people don't.
Yeah. Well, that's a perfect segue, Ian, into the next section. Thank you very much.
I do my best.
Hello, my name is Blair Tweedie. I'm a registrar at Northumbria, and today I'd like to summarise work from the Nottingham group comparing the STAR and mobility total ankle replacements. This is the reference for today's paper. Total ankle replacement is increasingly recognised as a viable treatment option for end-stage ankle arthritis, providing pain relief whilst also maintaining joint movement. This study compared two unconstrained mobile bearing prostheses, the STAR Scandinavian total ankle replacement and the mobility total ankle replacement. The main aim of this study was to review the outcome data for the STAR versus the mobility total ankle replacement. The primary outcome measure was revision rate, which was defined as any surgery where any implant component is changed or removed. Secondary outcomes looked at the prevalence of intra and post-operative complications and PROM scores as listed below, including range of movement and visual analog pain scales. Patients were referred to the tertiary treatment centre and were assessed for surgery using the inclusion and exclusion criteria as listed. All patients with less than 1 year's follow-up were excluded from the study. Treatment consisted of a period of pre-operative patient education. Surgery was performed via the anterior approach. Post-operatively, patients were placed into a below-knee cast but could weight bear as tolerated. Follow-up was carried out at the time points as listed, and this included radiographic assessment, range of movement and PROM scoring performed by a specialised physiotherapist. In total, 147 star prostheses were inserted between 1999 and 2005, and 162 mobility between 2005 and 2013. Age ranges for both groups were similar, as was the male-female split. The star follow-up is out to 14 years and mobility is out to 8, although the authors cite caution when interpreting data at these end time points due to the limited number of patients within this subset. The total number of revisions for the star prosthesis was at 27, 18.4%, and 8 for the mobility, 4.9%. When comparing at a set fixed time point of 7 years, there were 18 revisions for the star and 8 for the mobility, 12.3 versus 5.2%. Associated operations were carried out for either secondary deformity or new diagnosis. There were 20 in the star group and 15 at mobility. Most commonly performed procedures were subtalar fusion, lateral ligament reconstruction, and tendo Achilles lengthening. Revision surgery was defined as any procedure where a component of the implant was either exchanged or removed. This was due to liner problems, infection, instability, or loosening. In both series, 4 cases were converted to arthrodesis. This was due to component misalignment, infection, or chronic pain. The total complication rate was 16.5% for the star and 9.9% for the mobility. This included superficial infection, which was managed with topical antibiotics, deep infection, which required revision surgery, fractures, which either occurred intraoperatively and if undisplaced were managed in a cast, or postoperatively, which underwent open reduction internal fixation. When looking at secondary outcome measures, both prostheses were seen to provide acceptable and comparable range of movements. The mean score for BOFAS improved to 75 from a preoperative mean of 40 for both prostheses. No significant difference was seen for outcome scores in terms of BOFAS, FFI and EQ5D, and indeed there was also no significant difference in patient satisfaction ratings. In summary, the authors report that the mobility has a better survivorship and lower complication rate than the star prosthesis in their unit. Indeed, a complication rate of 9.9% for the mobility is lower than that as published elsewhere in the literature. The authors do identify some limitations. Most importantly, that both cohorts were recruited sequentially, and therefore there are confounding factors present as a result of surgeon experience and improvements in the surgical care pathway that have taken place over years. They still feel that the complication and survivorship profile for ankle arthroplasty is not comparable to that of hip or knee arthroplasty, and the authors ultimately recommend ongoing careful patient selection and for ankle replacement surgery to only be carried out by high volume specialised centres. Thank you very much for your time this evening.
Okay, thank you very much for that, Blair. So can I remind the attendees that the Q&A button is open, and if you have questions you'd like to submit, please use that. So I'm very pleased to be joined for this section of the evening by Sunil Dhar. Sunil, I maybe invite you to unmute and switch on your video. Many of you will know Mr. Dhar. He has an enormous reputation both here and internationally. He's a consultant at the Nottingham University Hospitals. He's been a past president of BOFAS and the British Limb Reconstruction Society, and he's offered sage advice to many of us on our journey to becoming consultants and development as consultants performing particularly ankle joint replacement. So Sunil, this is the latest paper that you published on the topic of ankle joint replacement. There are some questions for you, but maybe we could also ask you to offer your reflections on the paper presented tonight.
Well, thank you, David, for that introduction. I'm not sure if I entirely deserve it, but thank you anyway. And thank you to BOFAS and to James for inviting me to this journal club. So yeah, this paper is odd because it's a very recent paper, but you will see that it's not a randomized controlled trial. It's not one of those fancy evidence that the quality that everybody is gearing towards nowadays. But I think it's important. And the reason why Martin Ragland, my colleague, who's the first author, and I decided that we ought to really look at our historical patients was this, that there is quite a lot to learn from both of these implants. And particularly the mobility one, which is now pulled from the market, and you will most of you will know that. And it was to see why exactly that might have happened and how some of these market forces drive what we do as orthopedic surgeons. But I'll come to that in a little while. So my actual kind of ankle replacement journey is basically divided over 4 important years. Started in 1996, for instance, with the STAR, changed to the mobility in 2004 for a variety of reasons, which I can go into. Then to a smattering of other mobile bearings in 2014, because they pulled the mobility in 2014, and then ultimately to fixed bearing implants from 2016. So it's been quite a journey over the last 20-25 years. And what happened with the STAR, and when we started looking at this, was we were looking at the STAR in its infancy with instrumentation that was fairly primitive. So the series that's mentioned here is the series which was done using the original instrumentation that Håkon Kofod from Copenhagen designed, not the instrumentation that STAR have now evolved with the help of Roger Mann and Michael Coughlin in the States. And so therefore, I think that is very important to understand. That's how that might well have a very significant bearing on the difference in the results between the STAR and the mobility. There is, of course, the question of the learning curve, and having sort of learned about the implant from Peter Wood initially, and then gone on to use it myself, it was just always an evolving exercise. So there was a big learning curve in those days regarding ankle replacements, and that might have the other bearing on the results. The mobility we chose because it was then backed by some very eminent developers, including Peter Wood, and which was with what was perceived at that time to be improved instrumentation. I must admit that given the constraints of the implant, even looking at the results now, I am reasonably impressed. And if you compare this series to the previous paper, you will see that actually the complication rates or the failures are not dissimilar between the two papers. So it's quite assuring to see that that we were able to achieve the sort of results we did with those implants. So I think in that sense, studying historical patients as case series has helped towards better understanding of the evolution of ankle replacements and perhaps even where we should be going. The other important thing was the secondary procedures or the additional procedures that were done with those implants. So the list, if you look at our additional procedures nowadays, would be quite different to the lists that were presented in this paper. And every subsequent publication now that you will see with more modern implants, you will see that that list of secondary procedures is going to be quite different. We certainly see that in our unit. So overall, I think the paper does add value to the literature on ankle replacement. I think it's at best a level 3, maybe a level 4 series. it has, compared to implants, the data collected on a prospective basis, but obviously retrospectively analyzed with, as Ian said earlier, scores that were not completely validated for foot and ankle, and certainly for end-stage ankle arthritis purposes, such as the AOFAS. But nevertheless, it has an important bearing in terms of what was available then and the sort of results that one could achieve. We haven't looked at deformity, but then we looked at deformity in another paper which we published in 2009, and I think that was one of the first papers universally that actually suggested that you could deal with quite significant deformity if you added additional procedures, which now are recognized as part of ankle replacement. So yeah.
Brilliant. Thanks, Sunil. Very sage comments as always.
Yeah.
So we've got a couple of questions coming in. There's a question from Anirudh Gadgil, but I think you've addressed that in your commentary. Although I've been asked to answer it live. So the question is it possible that there were more complications and higher revision rate in the STAR because it was performed in the earlier part of the learning curve, and that surgeons therefore had a better understanding of ankle replacement by the time the mobility was being performed?
Yeah, I think we did discuss that. Yes, I think that is definitely the case. It has to be, and you will see that even now, I am learning with every passing month or year regarding ankle replacement. So that certainly was the case. And to be honest, when you look at historical cases and you think, gosh, did I actually do that? So yeah, there was a big bearing about those.
Yeah, certainly. I think, yeah, as a community of foot and ankle surgeons, the development in instrumentation, design, techniques just moved at a rapid pace. So yeah, certainly something to consider. So you've published in this the survivorship rates of the mobility in the STAR. You're now an even more experienced ankle replacer, and the instrumentation in all replacements, I think, has improved. What do you now tell patients when you're counselling them about total ankle replacement and survivorship?
So it's a very different conversation now with patients. I just to retract just for a second, if I may just have 30 seconds with this. So it's,
of course,
for me now, it's not a case of yeah, you can have an ankle replacement. It's a case of really thorough assessment, which we always did, but even more so now, of what the patient actually wants and what they are going to be doing with themselves, understanding that end-stage ankle arthritis is a disease of the young. So whether you fuse them or whether you replace them shouldn't be the debate. And I think Ian also pointed out to that, because there will be instances where you will do one or the other to the betterment of the patient. So in my mind, there's no debate about replacement or fusion. Each has its place. And as sort of specialized foot and ankle surgeons, we should be able to offer the appropriate procedure to the appropriate patient. So my conversation then is based on listening to what the patient wants and then gearing my treatment to that. And when it comes to the part of ankle replacement, then it has to include a whole host of other things which may or may not be necessary, depending on deformity, depending on what's happening to the rest of the foot, which is such an important bearing on the ankle, and obviously what's happening further up the leg. So the assessment includes, long leg alignment views, CT scans, etc. And the patient gets given a package then of what might be considered as a single stage operation or a two-stage operation, and sometimes even a three-stage operation. So there are certain caveats. I mean, I wouldn't do a subtalar fusion and an ankle replacement in a single sitting. for instance, for fear of vascularity to the talus. I would stage them. I would certainly do a significantly deformed ankle and say a midfoot fusion at the same time. I would certainly do, and I have a supramalleolar osteotomy, for instance, and an ankle replacement at the same time. So, you know, the conversation is much more involved now and based on the demands of the patient, essentially, and then you know, a protocol that's actually outlined. And you know, even if it takes the patient to get over all of that 12 to 24 months, they know it right from the start.
Yeah. Okay. I think, yeah, you raised that really important point that we all need to be offering ankle joint replacement and ankle joint fusion to the appropriate patients. And I think Mr. Halliwell's on the attendee list tonight, and that's certainly the message that BOFAS are trying to get out in terms of equity of access to both replacements and fusions.
Absolutely. And sorry, just to finish, the point about, you know, it should be done in specialized centers perhaps didn't come out quite as the way it should have. It's not so much a case of ankle replacement should only be done in specialized centers. It's a case of they should be done by a surgeon who's doing enough for those. And, you know, in Nottingham, we've run a couple of consensus meetings of what that number should be. I think it's important to have some kind of a limit to what you should achieve so that you can get better at it. It is a technical exercise. You practice it, you get better at it. It's as simple as that. You might be a very experienced surgeon in all other aspects of foot and ankle surgery, but you practice ankle replacements, you get better at it. And that was the only point. It's not to be done simply in specialized centers. On the point of revisions, though, I think that's another matter. I think that should be really a specialist revision, total ankle replacement. Yeah.
Okay, we've probably got time just for one last question because we're very near to 8 o'clock. So I'll hold you to a 2-minute answer. So we've obviously got, we have a number of consultants on the call. We've got a lot of trainees. So as a man of experience, what would you advise new consultants who are looking to start a practice that includes ankle replacement and ankle fusion, but specifically we're talking ankle replacement? What advice would you have? Well, you know,
as you know, end-stage ankle arthritis is about 10 times less common than knees and hips, so you won't get the same volume. It'd be great, well, it wouldn't be great, but if you did, then that would be another matter. So you really do need to consolidate your numbers. And we've looked at this, and a couple of ways of doing that is to form networks with your adjacent hospitals, to form groups with like-minded colleagues, so that you can initially start perhaps even operating together, so that you shorten your learning curve, and then you can branch out, maybe widen your indications a little bit. And the network is as a backup to difficult cases, to discuss cases with more white-haired colleagues, that sort of thing. And I think that would be the way forward for any junior consultant. I mean, we did that when I started. Even I had Peter Wood, Paul Cook to help, and went and sought their advice. And that's the way it should be. And nowadays, it's much more amenable with modern sort of communication methods, etc. So we've got a network that we've set up locally in Nottingham, and there's plenty of evidence that all of that works around the country. That will be the way to go.
Brilliant. Well, that's great. Thank you, Sunil.
Thank you.
So I'll close this session by thanking you, Sunil, for taking time out and joining us tonight, and your wise words. And I'll hand back to James Ritchie, who's going to sum up.
Dave, thank you very much. So just to conclude, firstly, I'd like to thank all the attendees for joining the meeting this evening. I'd also, of course, like to thank our panelists, Shilpa and Blair, Ian, Sunil, and my colleagues, Callum and Dave, for moderating this evening. Of course, I apologise once again for our slight technical crisis at the critical moment of the start of the evening, but nonetheless, I hope that has not ruined everyone's enjoyment of it. Certainly, I think we've had a productive and educational and thought-provoking evening. For myself, it's been quite a journey really to revisit Ian's landmark paper, which really defined arthroscopic ankle arthrodesis for many consultants of my generation. I've also very particularly enjoyed Sunil's opening a window onto the evolution or journey of development of ankle replacement over the last couple of decades. Those of you who know me will be aware I have a penchant for history, and I'm certainly not going to launch into a long lecture now. However, it's often said, following Edmund Burke's remark, that those who fail to learn from history are doomed to repeat it. So let us hope that we don't fall into that trap. Finally, of course, I'd once again like to thank our sponsors, DJO Orthopedics, for their very generous sponsorship of this meeting and ongoing support. I believe that we have a final video from them, and also at the end of that, you'll be shown the code which you can scan, the QR code, in order to get feedback and obtain a certificate of attendance for this evening's meeting. So once again, thank you all very much. Thank you to Robert and the IT committee. And well, let's have the final video, and good night.
James, I'm just going to interrupt very, very quickly, because one of the things that frustrates people when they've asked lots of questions is they don't get their answers. And I'm sure Sunil and I are very happy if people want to email the questions to us so that we can give our profound thoughts. Please do so. It then completes the loop, and I'm sure Sunil and I would be very happy to spend a bit of our dotage answering emails.
Absolutely, yeah, absolutely.
Thank you, gentlemen, for that very, very kind offer. I'm sure it'll be taken up.
The elite, standard, and short. Synonymous with comfort, control, and healing. The most advanced and lightest full-shell pneumatic walking boots available. Air Select. No other walking boot offers more. Soft strike technology dissipates force through the heel strike. A patented grid design puts a matrix of shock-absorbing material in contact with the heel. The result? Cushioning that reduces heel loading and prevents impact-related stresses. The integrated inflation system is easy to use. Patented air cells put the patient in control of a customized fit. Exclusive duplex technology combines the semi-rigid shell and overlapping air cells that produce a graduated compression to promote faster healing. And Air Select's semi-rigid shell has structurally engineered vents that maximize airflow and minimize mass without compromising support. Its unique shell is trimmable and heat moldable, making it easy to custom fit the boot. The Aircast Air Select series, the ultimate combination. Designed for comfort, engineered for healing.